Good morning. I've been doing this, not stirring the hornet's nest, but throwing a stone at the hornet's nest for the last 4 or 5 years. So every time I come to this meeting and talk about Cisternostomy, my friends are here. The reaction I get is in the first few years, and then it was like people started taking notice. And then, these days they're confused because they don't know whether I'm talking the right thing or I'm at least managing to confuse them. So instead of going through all the statistics and things which I will do, which I have to do, I'll tell you how I hit upon this idea, which will be interesting for you guys. What was the major surgical advancement in trauma? And trauma is the major killer in neurosurgery. Because we talk about skull base is glamorous. A lot of things are glamorous. But what's the major killer in my country, in India, or in many places? Trauma is the biggest killer. It's 10 times more common than aneurysms. Yeah, we do aneurysms, yes. But trauma is the major killer. And what happens to trauma? Thing is, no senior consultant operates on trauma. Residents who want to learn neurosurgery, they operate on trauma. They take frontal lobe, they take temporal lobe, yes. Next day we ask them, next day we tell them, chastise them, yes, why did you do that, why did you do this, yes, finally. But the end result is, nobody puts a microscope. It's temporal lobectomies or frontal lobectomies are accepted norms. Microsurgery has no place in trauma. And this is what we found. And this is the major killer, yet this is the major killer. It's an emergent situation. So no senior consultant would want to take his, down to the theatre at 2 a.m. in the morning. But if there's an aneurysm, 2 a.m. in the morning, they're there. So this is what I intend to change a little bit. I know I can't change it too much, but my question is, why don't you put an aneurysm into trauma? And let me tell you, don't think trauma is less glamorous, it's most difficult. It's very difficult. If you want to get into a space in a swollen brain, we talk about doing suprabrow craniotomies, we do it all the time. Suprabrow craniotomies for a ruptured anterior communicating artery aneurysm. People think it's impossible, it's easily possible. Why can't you do the same thing? Why can't you do a craniotomy and get into when I say why you can do a terional craniotomy and get into the intraoptic system, people say no, it cannot be done. But suprabrow craniotomy for a ruptured anterior communicating artery aneurysm, everybody knows it's done. Now 4 observations. Number 1, trauma and acute subarachnoid hemorrhage look similar. 2, opening cisterns for subarachnoid hemorrhage gets the brain to be lax. 3, opening cisterns in other pathologies also gets the brain to be lax. And, I have a lot of Russian papers which says cutting the tent was practiced in the 1960s and 1970s, cutting the tent, getting into cisterns was practiced in China and in Russia. And when I met the very senior professors in India, they said, we used to do that, but then it died off. So we have papers in Russian, we have some papers which say oncohippocampectomy, but why would you do an oncohippocampectomy in trauma? It's definitely not for epilepsy or it's definitely not for memory, it's to get into the system. So this study started in 2007. Now it's a bit retrospective and a bit prospective. So I didn't design it properly as most neurosurgeons do. So what I did is I started doing decompressive gemicraneectomies. We had a lot of them in Vellore. So after this in Alleppey, I was practicing as a consultant. I thought, why not open the cisterns along with decompressive gemicraneectomy? So this is what we started doing. You can see the statistics, 284 patients with decompressive hemicraneectomy, just that. So this is what I'm comparing. 272 with decompressive hemicraniectomy and cysternostomy. But then this was my learning phase. I mean, I took about 300 patients to kind of get to where I am right now, because initially I tried to open the sylvian like in aneurysm surgery. It's impossible. It's stupid. You cannot open. If you take time, you open the dura in a big C shape for a patient who's got. In decompressive hemicraniectomy, you open the dura, you put duroplasty, and you get out. You wait like that, brain will start coming out. I'm telling you, the brain will start coming out. So, if you try to open the sylvian, in a decompressive hemicraniectomy, it's stupid. Brain will come out on you. It will be merciless. So then, I figured out which system should I open first. So then I understood, probably it's interoptic, because it's the fastest. And then, I slowly went on to do the opticocarotid, then like for basilar artery aneurysms, I opened the membranofluidic vest, got all that, as much as systems that I could open, make it into one cavity. And then I never use bipolar. Again, that's one thing. People think there's bleeding, there's oozing, it's bipolar. No, don't use bipolar. You just irrigate, and I'm sure a lot of people have said this before, and it works. Most of the time, unless there's a really, pumping bleeder out there, which is very, very rarely the case. So you can just use irrigation. It will help to soothe the brain. Okay, now, how does this work? This is what I was asked. People, first time they dismissed me, and then they told me, how does this work? So, let's talk about Monroe-Kelly doctrine, the usual Monroe-Kelly doctrine. It says that, I'm sure the young neurosurgeons are here, so it says that you have blood, CSF and brain. So, when you have blood, CSF and brain, and you have trauma, you have raised ICP, what do you have to do? You have to decompress. Why should you decompress? Because pressure is inversely proportional to volume. So, the simplest thing is open the nut. Take off half the skull. Allow the brain to expand in a grotesque manner. The ICP will come down, therefore the CTP will go up. And this will save secondary injury. Now, the thing that you don't consider is, there's 120 ml of CSF in the systems. 120 ml of CSF in the system. I was talking to Professor Schroeder the other day. He also told me this is impractical. Yes, this is what I've been listening to 5 years. Yes, it's impractical. 120 ml of CSF, where does it go? In trauma, do you see cisterns? When you take up a CT scan, do you see cisterns? You don't see any cisterns. It's a tight brain. So people ask me, when you're opening the cistern, what cisterns are you opening? There's no cistern there. What are you opening into? Yes, that is correct. But where did the CSF go? Some people tell me it's spinal subarachnoid space. Some people tell me it got absorbed. Some people say, actually we haven't thought about it. Where did the CSF go? Now, since we have neurosurgical training and we know that it's been proven ultrastructurally that CSF cannot go into the brain, this is our undoing. But if you ask a medical student, or if you ask a 10-year-old child, let's say you put brain around that CSF and then you see an expanded brain but no CSF, where does it have to go? Where should it go? Logically speaking, it should go into the brain. Now this is very stupid by neurosurgical standards. Very stupid. But this is what happens. I'm telling you, this is what happens. And where does it, does the brain have channels to allow the CSF in? Now I know there are a lot of studies in neurophysiology and everything which says that none of the brain cannot allow. But you forgot the Virchow-Robin spaces. The Virchow-Robin spaces, the perivascular spaces, why are they there? Everything has a function. Why are they there? So So then I read a lot. I read almost all the literature possible. Why does it work? Then I thought, there must be CSF transport through Varsho-Robin spaces. Now, you must understand, for most of my neurosurgical career, I stayed in Nepal. We have a 0.3 Tesla MRI. That's all. I mean, we have. We have a 2-slice CT scan. Fortunately, I have an ICT microscope now because I do vascular cases. I have an ICT microscope. We have user drill. But imaging-wise, I have literally nothing. So I have to sit down and see. I have to read books and see what works. So we don't have diffusion-weighted imaging or MR elastography and things. I mean, I know these are all fancy tools which I could have proven my thing. But then, I didn't have anything. So I had to sit down. I had to take my pen and paper and see. This is what I'm telling you, it's possible. Sometimes it's better to take, as Professor Roy was telling, navigation sometimes it's like, I know it's a beautiful tool sometimes, but sometimes, most of the times it's like using GPS to go home, as he said. So, sometimes you have to sit down with the pen and paper and see what's happening.